Hello everyone, and welcome to our Multi-Modality Imaging Conference. It's a pleasure to have you, and September is the beginning of our academic year here at Houston Methodist and many other places. It's great to have you. I'm William Zoghbi. I'm the chair of cardiology here at Houston Methodist, and we usually start with general topics in imaging. So this one is no stranger to any of you. We'll start with echo Doppler, the basics, physics, but also in the next few weeks we will be addressing the basics of CT, cardiac MRI, nuclear, as well as PET. It's a great primer for us to start looking at what goes behind the scene in imaging. And later on during the year, we will address its applications, advantages, disadvantages, and the nuances that you really need to have as you engage in cardiovascular imaging, and be it any trainee or even specializing in cardiovascular imaging. We want these to be interactive, so I'd like you, if you're on the web, to join us on the web. Go to paulev.com and enter DeBakey and respond to the activity. Or if you want to use a text, text DeBakey, D-E-B-A-K-E-Y, to 37607 and text in your message. It would be great to interact towards the end of this session. So let's go ahead and get started talking about echocardiography and the basics of echo. For those of you who have been in the field for some time, you know, the journey has been amazing. It is nowadays a family of techniques, from M mode to 2D, Doppler, 3D, and color Doppler, and all the applications that nowadays we're very familiar with. And it's important also to understand, you know, how they're made, what are some of the technical issues that you really need to know about. So ultrasound, as you know, there are waves and their properties, and the way, you know, from a basics point of view, this is the wavelength of that ultrasound wave. One cycle is a wavelength. The frequency in hertz, as you know, is the number of cycles per second. And in ultrasound, the word tells you it's beyond the sound, so that we don't hear these sounds. Actually, they're in the megahertz. The speed of ultrasound in biological tissue is 1540 meters per second, and the properties of reflection, refraction are similar to light. So the longer the wavelength, the lower the frequency, the shorter the wavelength, and this is really basic, the higher the frequency. So if you take a look at this ultrasound transducer, and in a transducer at the tip of it is piezoelectric crystals, that they are either responsive to mechanical stimulation or electrical stimulation, and they emit, after you stop exciting them, they'll emit a burst of waves, and I think that's the beautiful property of them. And as you know very well also, for us to be able to send and then receive and listen to these, we send usually bursts as opposed to a continuous emittance of these waves. So that burst goes to, if it interacts with a surface, some of it is refracted, go beyond even what you're measuring. So if you're imaging the heart, is going to go even beyond, and probably to the lung, if it has enough energy. Some of it will be reflected back, and very little of it actually will come back in the direction of the transducer. And interestingly enough, this is actually what you will be able to see. So it's a very tiny fraction of what you're sending, you know, from this ultrasound transducer. Now, you hear about A mode, B mode, and M mode, and most of the time you don't even talk about them anymore. But I think it's important to just think of how things are constructed. This is the burst of packet, and this is a more reflectant, you know, tissue, let's say calcium compared to a soft tissue. And A mode is the amplitude of that reflection back into the transducer that you're registering, and it has a certain amplitude. That's why it's called an A or amplitude mode. If you flip that 90 degrees towards you, you'll have the B mode or brightness mode. And interestingly enough, yes, that's what your 2D is made of in a way. So that is the brightness mode. And then on an M mode, which is motion, it's not M for mitral, it's M for motion. is if this dot does not move at all and you have a time domain for it, it will stay as a flat line. And if it moves up and down during any motion, cardiac cycle or otherwise, you're going to see it going up and down. The beauty of an M mode, again, is certainly its time resolution. So these are cardiac M mode. If I send this ultrasound beam in the direction of the aortic valve in the left atrium, you're going to see the aortic valve opening for a very short period of time and then closed. And this is the wall of the left atrium and back. If you're interrogating, sweeping down towards the mitral valve, you're going to see its opening of the anterior and the posterior leaflet. And if you enter the ventricle itself, you're going to see part of the right ventricle of free wall, and then septum, it's thickening throughout systole. And diastole thinning, and the posterior wall, and if there is a pericardial effusion posteriorly, you will see it right there. So now this is 2D, and we alluded to that, and the first is in 2D is actually what is happening is we are sweeping this ultrasound beams that are going through, and that sweep is quite fast, could be 160, 200 times per second. So the sweep is quite fast, and as you could see, the reason for it, we emanated from one place here, is you have to go between the ribs for you to be able to see the heart. So the spacing of these small beams is larger further away, which adds to the lower resolution, going forward down the line. So few important things for you regarding resolution of the images that you're assessing. If you're looking at axial resolution, basically in this axis here, if I want to resolve two different dots, saying that this dot is a little different than this dot, the higher frequency I have, obviously I'll be able to resolve these two dots better than if I have a lower frequency transducer. And believe it or not, also it is the highest resolution that you can get with ultrasound. So axial resolution. So if I want to take a look at the interatrial septum, the best resolution probably would be from the subcostal window, because I'm perpendicular to that structure. And the same thing for the septum, if you will, and the posterior wall. The same thing for the septum, if you will, and the posterior. So let's talk about lateral resolution here. For the septum, if you will, and the posterior wall. And the same thing for the septum, if you will. I hear my echo here. Let's talk about lateral resolution here for the septum. All right, I stopped here just because I could hear myself. So let's do that again. Lateral resolution. In the lateral resolution here, this is the ability to differentiate between two dots themselves in the lateral portion as opposed to in the axial resolution. And as you could tell also from the beam itself, unless you focus it, the beam will get larger. So these two will be like one dot only as opposed to two. And for you to be able to have two dots resolved, this beam has to be narrow, and that's where at times you can focus it electronically to narrow it as much as possible. Still in the far field, your lateral resolution is much worse than proximally. So some instrument controls, I think these are important. Overall gain, TGC, which is time gain compensation. Remember, almost everything is time, right? For us to be able to tell how deep a certain structure is, basically how much time did it take from the ultrasound emanating from our transducer, reflecting and then coming back. Reject and compression. So all the other things here are actually post-processing. And the only thing that you're changing truly in energy sent towards this heart, if you will, or any vessels that you're imaging is a mechanical index of the output power of that transducer. So if you take a look at the mechanical index itself, the mechanical index, which is that power, basically is peak negative pressure divided by square root of the frequency. Now this becomes very important in penetration, but at the same time, It's very important when we use contrast down the line is this peak negative pressure here. If it is very strong, these micro bubbles will burst. So one is safety, and I think it's already regulated that we're not going to use a very high energy to destroy tissue. But also now from an applications point of view, penetration, you'll get more mechanical index for you to be able to penetrate and see better for difficult patients. And also you have to be very careful regarding contrast per se. Few things that also you may see once you start imaging. One is reverberation and attenuation. Actually, you see this on a transesophageal, in this case with a prosthetic valve, in addition to a thrombus and some heavy calcifications, if you will. This is the reverberation. And the reverberation is occurring because of some reflection of ultrasound back and forth within this mechanical mitral valve. This is attenuation. Most of the ultrasound is being reflected back. And what you see is blackness behind this because there's no further ultrasound that is going down to be able to be reflected back. So these are things that you will see when you start imaging. Here, you're going to have quite a bit of reverberations, if you will, but these reverberations are between the apex of this heart as well as the transducer itself and its casing. So you see this, what looks, soft tissue, et cetera, and the question is this thrombus, yes or no? And for you to be able to differentiate that, you may change the frequency of your transducer. You may change the position of the transducer for you to be able to image this heart, or use contrast, obviously. And here we've used contrast to try and differentiate what we're seeing. And you could see a left apical thrombus very nicely in this area. Now, many technologies using ultrasound, and this ultrasound is still the same principle, is sending, waves that are in the ultrasound frequency range, and then processing, the image back. Nowadays we have full digital system, high frame rates, multi-frequency transducer. In the days when I trained, you had to change every transducer, a 3 megahertz, a 5 megahertz transducer, you have to change that. Harmonic imaging is integral nowadays, and I think we'll be talking about that. Tissue Doppler, digital storage, as well as real-time 3D. Harmonic is very important. It's a great actually discovery because the investigators were looking at use of harmonic with contrast itself, because these tiny microbubbles would resonate and emit multiples of that frequency. So harmonic refers to, this is your fundamental frequency that you're sending the ultrasound at. And if you hit a certain object with that frequency, it may emit multiples of that, or even a sub frequency of it. And your best example probably in real life is if you play an instrument, a metal instrument, either a guitar, a string instrument, a guitar or a piano. If you hit it very hard, it will send, besides its own frequency, a multiple of it, making noises like this, that if you hit it hard. So the same principle applies here for the heart. And it's interestingly enough that we never thought that the heart itself, the muscle itself, would emit a harmonic, and it does, because there is a property of that harmonic is that it decreases clutter, so we can see the apex much better than if we did. And as I mentioned earlier, it was initially not discovered but worked on to try to image better contrast and perfusion and contrast within the blood cavity as well as the myocardium. And I think nowadays imaging itself of the heart itself is better, because here you cannot see the apex well, and now this is harmonic imaging, and these are from earlier images. So the images certainly have gotten better and better and better. One problem with harmonic, obviously, if you're sending at, let's say, 2 megahertz and imaging at 4 megahertz, the resolution is at the 2 megahertz frequency. So don't fool yourself that, if you're imaging at 4, that indeed this is the frequency that you're imaging at. Always try to image at the highest frequency that you can, And I see that at times in our sonographers or our trainees, that they gravitate towards a lower frequency image, and it will give you a much lower resolution and much more grainier image quality. So try as much as you can with the highest frequency transducer. And yes, you could use a harmonic most of the time, but at times you may want to use just fundamental imaging for best resolution. Let's talk a little bit about contrast. We mentioned a bit about contrast because of the properties of harmonic, etc., etc. So this is certainly a very difficult image in a person, and you could use contrast here. It really just like the lights went on, and it resurrects your images and your ability to interpret these images. One thing that there are a few things that are important when you use contrast. Fundamental imaging per se. If I use contrast here, I cannot differentiate very well my cavity from the myocardium per se. And remember that if you use harmonic imaging with contrast, you're going to enhance the signal so much more from the contrast per se. And you could see this is just few seconds apart by turning an H, which is harmonic as opposed to just fundamental imaging. And notice how bright the contrast is. And actually I can start differentiating between the cavity itself and the myocardium. So it's really very nice. So you have to kind of keep that in mind when you do it. Okay, so we talked about imaging, various M mode, 2D, use of contrast, and now let's talk about Doppler. And Doppler is basically using the same waves that we're sending, but we're asking a different question. And the different question is how much of a frequency shift has occurred. And there are spectral, color, certainly continuous wave Doppler. This is when I visited Salzburg a while. This is where Christian Doppler was born, and actually his museum is, or at least the place of birth, because there's no museum for him. This plaque is very close to Mozart's museum, and where Mozart actually spent quite a bit of his days there. So when we talk about the packet of ultrasound that we're sending. Interestingly enough, that these packets of ultrasound, or any sound actually, can be deformed depending on if they hit or they see or they interact with a moving object. So probably the best examples nowadays is, if you're standing close to a train track and you're seeing a train coming in, you can hear this frequency that is emitted, the sound is emitted. It increases in sharpness and pitch, and then it decreases in pitch when it goes away from you. So you can hear it going, accelerating and then going down. Actually, if you close your eyes, you can tell actually that this train or ambulance is coming towards you or going away from you. But if you're perpendicular to that, far away and perpendicular to it, you're not going to be able to tell that. So it tells you two things. It relates to velocity, and also it relates to some angulation. And this is where the Doppler equation came from, Dr. Christian Doppler. So it can tell you about, here, this is an example from the aorta itself. If the velocities of the red cells are going away, you're going to see them displayed going away. If they're coming towards you, they'll be coming towards you in there. And this is the equation, the Doppler equation. Now, nowadays, what you see on the y-axis is a display of velocity. Basically, it is solving for the Doppler equation. The Doppler equation is delta frequency, right? The change in frequency of that fundamental frequency, the emitting frequency of that transducer. Notice that there is a constant of the velocity of sound in the tissue, but also there is a cosine theta, which is the angulation of the ultrasound beam with the velocity that you're trying to interrogate. So at 0 or 180, this is 1 or minus 1, but at 90 degree, there is no frequency shift. So the velocity is 0. It doesn't mean that the object is not, or the red cells are not going at a certain velocity, and therefore the dependence on angulation. Now, most of the time we allow about 20 degrees or so angulation, because beyond that the errors becomes really hard. And the best actually in acquisition of these velocity, let's say in the LV outflow tract where you have some angulation, is to get the best velocity from different windows as opposed to correcting for the angle, because you don't know exactly where the vector is going in 3D. Okay, so pulse Doppler, so this is one of the methodologies of Doppler, is basically the same principle in a way, but I listen at a particular, time period. So my burst of ultrasound went, and then it's traveling throughout. And let's say if I'm interested in the red cells moving at this stage here, I have to listen, wait time-wise, for the ultrasound beam to go down and come back and reflect, and then I would listen for a very short period of time. So I emit, wait for that distance, which is time, and then open the listening device of that and analyze the data that's coming back. So this is pulse Doppler technology from the apex, looking at the LV outflow tract, and this is processed. The changes in frequency are processed by fast Fourier transform analysis, which is among the best things that we could do nowadays. And you could see here, most of these red cells are going at this velocity here. There's frequency dispersion, which tells us that some of these red cells are going faster and some of them are less, right? Modal velocity is here somewhere in between. This is maximal velocity, this is the lowest velocity. So usually a very sharp the ascent when you have an ejection, and you could use that for interrogating any other place, and this is the mitral inflow interrogation, use function assessment, etc., etc. Now there is a concept of aliasing, and remember, since this is we're repeating this pulse repetition frequency, we're not sending ultrasound all the time, right? So it's almost like a strobe, right? If you go to a place, a nightclub or other places, and depending on how fast the motion of that individual or that ball in relation to the frequency of light that you're sending, same thing appears here, is that you may not at times be able to tell what the actual frequency is. So the pulse repetition frequency must be at least 2 times the Doppler shift in order to correctly determine the polarity of the shift. And we could do a baseline shift, so we can acquire almost double of that information, but beyond that we will have aliasing, right? So if let's say this velocity is too much, half of this display is put below, and then you could do some baseline shift, gain almost double of that scale, if you will, if you know which direction the red cells are going. So this is to try to play around and overcome some of these limitations. But if the velocity is much higher than my pulse repetition frequency, what will happen is you'll have aliasing, and this is mitral regurgitation as opposed to mitral inflow, and you'll have this spectral broadening throughout here that you're not going to be able to tell what it is. Okay. Now this is color Doppler, and color Doppler is actually a poor man's method of pulse Doppler. And why? Because we wanted information as to the direction, if you will, and maybe the velocity. And this is an estimate of the velocity, so you can think of multiple sample volumes right here throughout these scan lines. And these multiple sample volumes are asking not a fast Fourier analysis, because it will take much more time. This is an autocorrelator of estimate of mean velocity at each site. The aliasing velocity is usually lower than that with the regular pulse Doppler, but at least it will give us information as to flow in a particular chamber, right? And because it takes quite a bit of time, we have to be very careful, time to be able to process the data, as to optimize these images. We don't want it to be too stroboscopic. We want a frame rate at least above 15, closer to 20 and above as much as possible, for you to be able to image, the flow itself. So it's a multi-gate, Doppler with sample volumes, and this is a color Doppler of a mitral regurgitation. So it tells us about the extent of it, its direction, not necessarily quantitate it itself unless we use, the PISA methodology or the vena contracta, and we can talk about these, sometime down the line. Now, if you change direction, right, so color coding is red or yellow coming towards you, bluish hues going away from you. It took some time for people to accommodate and agree on these back in the late 70s, early 80s. But if you change direction, remember this is perpendicular to flow, the ultrasound. So it's a blackness. There's a black area because not the velocity is 0, but you're at an angle of close to 90. So whenever you see a change in a period of blackness, you've changed the direction. What are the factors that influence color Doppler? Gains are important, color map, with or without variance, frame rate, this is very important, and Nyquist limit. And if you tell me about what are the most important thing, gain, you cannot undergain. Frame rate, you want to optimize it. Nyquist limit, you want to make sure that you haven't dropped the Nyquist limit too low. This is the effective gain. And the accepted methodology, we don't have an optimal gain automated. The optimal technology here is to make sure that you're at highest gain and bring it down so you don't have as much, almost snow in the background or too overgained. But you could, change your estimation of what the colored jet area, if you will, or if you overgain or certainly undergain. At times I see that is you may mask a significant regurgitation if you're too low on your gain. The other thing is Nyquist. If you drop the Nyquist limit too low, what will happen? You will overemphasize all the flows that are lower velocity, whatever that chamber is. So this is a mitral regurgitation with a Nyquist limit of 21. And notice when you get a Nyquist limit in the acceptable range for flow interrogation, and usually above 50, close to 60 or 70, right? If you take a look at these flows that are much less impressive, yes, you're emphasizing the low velocities everywhere, basically in that sector, but this is your better assessment of mitral regurgitation, at least from a severity point of view. So the other things are scan depth and scan width. Frequency of the transducer, you don't want to have this scan width too wide beyond the area of interest, particularly if you hone down on it, because it will slow your frame rate down. Line density, we usually don't change it as much as how many times you go through that scan line before moving to the second one, before moving to the third one. And most often, people use about 3 times before you go to the second ones to try to improve the accuracy, if you will, but you don't want to overdo it. Your frame rate will be too low. And so we talked about in the scan depth. Now, obviously, you'll be limited by the depth at which you want to interrogate. If I bring this one down further, but my depth is still here, I'm not going to change, the frame rate. So it will be towards the end of the area of interest. That will determine the frame rate of your color Doppler interrogation. High PRF or high pulse repetition frequency, this is where at times you can fool the system if you want to interrogate. We used this much in the earlier days of trying to interrogate, let's say, a jet and a mitral regurgitation jet or an aortic stenosis jet, where we had problems with, getting these by CW per se, so the direction. So you increase the frequency closer to what your area here, and because of that much higher pulse repetition frequency, I will be able to record the jet without much aliasing if it is further away. So I'm tricking the system in a way to be able to get to almost to a continuous wave Doppler. Talking about continuous wave Doppler, the difference here is obviously, just like the word says, you're sending from those crystals continuously an ultrasound beam, and you're recording the frequency shifts at the same time in that crystal that is dedicated to one sending versus receiving. And that's why with CW you don't have aliasing. Basically, you adjust your scale And if you see something looking like aliasing, it is not because of aliasing. It is the red cells are usually moving in a different direction. There are vortices, there are eccentric jets that are coming back and forth in different areas. So it's not truly aliasing that you're seeing. So you can always adjust that to get a very high velocity recording of whatever velocity you're looking at. Tissue Doppler imaging, another application of Doppler, is in this area. For many, many years we used Doppler mostly of the blood of the red cells in the cavities of the heart and in the aortas. And we ignored deliberately what looked like interference or areas that were not of interest to us. And that filter is not too hard to do. And the reason for it is the Doppler that is shift that is obtained from the myocardium is stronger, much stronger, because obviously the density of the myocardium, and much lower velocity as opposed to a softer and higher velocity, and that's why you could differentiate that. And then came a true new area for us, I would say close to 15, 20 years ago now, with all the tissue Doppler imaging and applications in myocardial function, diastolic function, everything else. And then probably the most impressive thing afterwards came with speckle tracking imaging. Why? Because with Doppler, there is always and we'll talk about that a little later, there's always an angulation issue. So if the myocardium is, let's say, in the apex and you're imaging from the apex, you're not going to have a frequency shift. And comes speckle tracking, because now we're angle independent. And I think that was one of the most beautiful presentations I listened to during that early presentation of this discovery. Now we can use that either Doppler or speckle tracking to look at strain, which is deformation of this heart from a certain baseline situation. So we're talking about systole, for example, and there is a shrinking of this heart, minus 20%. So it is change in L, the length, divided by the baseline L0, and this is stretching of this heart by 20%. And if there's no motion, there's no deformation, actually, it is 0%. So we talked here about strain and strain rate. Doppler, we're not using it as much because of angle dependency. Speckle tracking, that's what we use most of the time with its application in global longitudinal strain, radial strain, and the others. And strain rate is the rate of that deformation. So let's take a look at here, and this is strain rate depicted. So we know what deformation occurred, and this strain rate is much slower than this strain rate. So the amount of deformation was exactly the same, just the speed with which the deformation occurred, which tells us something about, probably for the heart, about myocardial properties. We don't use it as much at this state of the game because it still has some errors and lesser reproducibility than strain per se, but I think at least you understand the concept of that. 3 types of strain. Most of the time when you talk about, let's say, GLS, and that's most of the time what we use, it is in a strain in one direction. Remember, the heart is deforming in systole as well as in diastole in 3D. So there is a component of circumferential, there is a component of radial, and there is a component of longitudinal. Take an example, for example, is somebody with hypertrophy. We know that GLS is reduced in patients with hypertrophy, yet the radial strain is increased. So if you think from a functional point of view, for that heart, the output of that heart may be similar or enhanced at times, but the properties of the heart, depending on where the myocardial layers and the orientation of the fibers are, deformed in a different way, and it may have some prognostic implications by themselves too. So take a look at an example here. This is strain and imaging on the right side. This is GLS, and you could see in different areas of the heart, most of them are deforming very nicely together. And you get a map of that deformation, and this is certainly a very poorly functional heart, almost globally actually. And the applications of it, I don't have to tell you, they're tremendous nowadays for cardio-oncological areas, for areas of dysynchrony, global function, prognosis in patients with hypertrophy or the like. Digital storage, I think it's interesting. We take it for granted nowadays, our new trainees. We lived through the days of videotape. We lived of the days of offline digitization. Nowadays, it is so nice to be able to have that, and don't take it for granted. But I want to emphasize one important thing, is since echocardiography is so operator dependent, yes, we have protocols, but we are very operator dependent. Take the digital echocardiography and different displays of this heart for you to decide which ones to measure, which ones to quantitate. Let's take a look at here, for example, the LV outflow tract. If I wanna, this is not probably the one I would use. It gives me a choice of where I could use. You could, zoom on it, et cetera, et cetera. Same thing for regional ventricular function assessment. Nowadays, with artificial intelligence and machine learning, some of the companies are working on displaying actually, I want all the views that show me left ventricle, all the views that shows me a certain valve. And I think we're working towards that goal so that it enhances your overall interpretation while at the same time displaying all these nice images for you to be able to interpret that. 3D certainly has had quite a bit of an impact, particularly ventricular function and some for valvular heart disease. I always keep showing this because this is in the earlier days of TDs. This is 2003. The images were not too bad. But in 2003, and this is actually from one of our fellows, I keep it from a historical perspective, who is now not a fellow, but certainly an attending and a big shot too. We're not going to identify this individual, but it's great to be able to see that and the applications of 3D, either real time or basically a 3D total volume of this heart for you to be able to bisect it in different ways and better, hopefully have better assessment of ventricular volumes, overall ejection fraction, which I think would be very important, particularly when you have somebody with different regional wall motion abnormalities. We always hope for enhancement of these 3D with contrast. And our companies have really not optimized that yet, and I do hope that industry will optimize it. Frame rates have improved significantly over time. This is high frame rate, and you can get also 3D global strain, just similar to what we talked about. And getting to current day imaging, really the images are really beautiful, particularly from a transesophageal point of view. It's almost looking at the anatomy of the heart and in function in front of you, which is superb for us to be able to do that. You can combine that with a Doppler echocardiography for assessment of regurgitant lesions or abnormal flow. We can quantitate that with modifications of the PISA methodology or vena contracta and regurgitant lesions. So many of these apply to much more from the transesophageal approach, but I think further enhancement in resolution will certainly help when we be able to quantitate using 3D approaches. And some of these newer basically techniques of enhancing our images, it really is quite impressive of just how advancement in computer technology have enhanced our ability to be able to image this heart using the same principles of ultrasound. So on this time trends, if you will, of developments of echocardiography from the A mode, M mode to 2D Doppler, color, TE, contrast, tissue Doppler, live 3D, speckle tracking, live 3D TE. And I know we haven't talked about handheld, but handheld is really amazing that you could take it portably to the wards as a screen for any abnormalities with a truly tremendous ability to image. I usually like to end with a reflection back, and this is about 61 years now. This is a recording from Dr. Inge Edler. just to maybe re-emphasize for our developers as well as our trainees and fellows of how far we have come. And this is from Dr. Inge Edler himself and his assistant, examining a patient with ultrasound technique. So within 60 years, basically, look at how much have we improved regarding imaging technology using the same principle that was there and its applications, put to forth by Dr. Edler himself and colleagues later. So this is it. This is the ventricle and the mitral valve being examined in 1960. And just imagine how much we have come along the way. So thank you very much for your attention. And I know there may be some questions that you want to share with us. And I see here, why is the Nyquist limit half of your PRF? Because actually that's, if you go through the physics, you have to at least have to be able to because of the frequency shift that you're dealing with in ultrasound. What role does audio and light play with frequencies? Audio and light play with frequencies. Not understanding that particular question, but I'll try to flip it one way or another. If there is, in the past, we used to have audio during recording of these. We used to be able to split the audio as the one coming towards you versus the one going away from you. Nowadays, audio for our interpretation is not as important. At times, audio also, if we're talking about the signal itself, it can tell you about its pitch and therefore the velocity. So just imagine if you hear an audio of a mitral, let's say inflow or LV outflow tract versus a continuous wave Doppler of an aortic stenosis jet. At times, if the velocity is so high, you barely can hear it, and depends on how good your hearing is. So if this is the intent of that question, you can tell how high the velocity is and whether it's coming towards you or not by just listening to the audio without looking at the spectral display at all. All right, I think I don't see any further questions. Hopefully you enjoyed this, and again, welcome to our series. I will be, for those of you watching live, will be every Tuesday at noon Central Time. But I know with so many of our followers on YouTube, you can do this at your leisure. Join our 60,000 plus followers on YouTube, and have a wonderful academic year.